Hello, everybody. This is Dr. Pritpal Singh Mathreja, an MD Pharmacology from CMC Ludhiana. And today I'll be talking about yet another competency as per the CPME curriculum 2024-25. And this curriculum says regarding the competency PH3.1, which says describe the type, salient pharmacokinetics, pharmacodynamics, therapeutic uses, adverse drug reactions of general anesthetics and pre-anesthetic medications. Now, I plan to conduct this session in a series of two videos. In the first video, I'd be talking about the general features, general salient properties of the general anesthetics. And in the second part, we'll be talking about what exactly are the drugs and where we can use these drugs. So I hope I'll be able to give you some insight into this topic of general anesthetics. And if there are any doubts or any queries regarding this, you can write down on the chat box and I'll definitely get back to you. So let's start with this particular process of general anesthetics. So when we talk about general anesthetics, the first thing that is there is that we need to differentiate this general anesthetic from local anesthetics. The local anesthetics, as the name suggests, implies for a particular localized area, whereas general anesthetic, we are talking about the generalized body where the CNS is depressed. So now the next question arises, why exactly do we need anesthesia? So let's take you to a time when we did not have this particular process of anesthetic techniques. What was the procedure at that? Let's see this particular early surgery being performed in the home. And what do you see out here? You see an amputation being performed, and you have two people catching hold of the person, the other person going ahead with the amputation. You could see a knife in this particular man's hand. This particular man is crying for mercy, severe pain, and a lot of problem associated with this. So it was like a painful experience that each and every individual had in earlier part of the century when there were no anesthetic agents at that particular time. So then there came a transformation, a transition, and this was there in 16th October 1846, which is celebrated at the World Anesthesia Day. This is the Ethereal Dome in Moshe General Hospital, where a particular surgery was performed using a general anesthetic, and this is one of the landmark discoveries of the previous centuries. Now, uh, there has been a transition from that particular time. Now we had this chloroform, and what happens with this? So now you see out here a physician administering chloroform out here. Now, what is the problem with this? Why, if you administer chloroform out here, there is obviously some problem that the physician, other persons might be able to inhale it and might have some manifestations of this chloroform which might not be required by them. So this was another drawback that was there. So now coming back to the definition of general anesthesia. So general anesthesia is a pharmacologically induced state of reversible loss of consciousness, analgesia, which means pain relief, muscle relaxation, and reflex suppression. So I told you in the one of the previous pictures that you could see the person holding his hands together to get don't for the amount of pain that he was suffering. So now general anesthesia has four components. The first one, loss of consciousness, analgesia, muscle relaxation, and reflex suppression, and all this is reversible. The most important part out here. Now let's proceed, Bandit. Now this is a modern day machine which you see a lot of monitors placed, and there are some flasks placed out here, a device set up for monitoring of the patient. You have various tubes that are there. So a lot of transition has occurred. This is some modern, you could see monitoring of the patient with the ECG, the vitals, the BP, the heart rate, all being monitored effectively, and even the oxygen saturation being monitored in the patient. So this is the modern day. general anesthetic. Now, when we talk about the general anesthetic, we should often have a triad of general anesthesia, and this triad includes three components. The first one being hypnosis, the second one being analgesia, and the third one being muscle relaxation. And when this triad is fulfilled by any of the particular drugs, then that particular drug acts as an anesthetic agent. There is a possibility that one drug might be a good hypnotic but not an analgesic. A drug might be a good analgesic but not a muscle relaxant or a hypnotic, and so on. So, a lot of permutations and combinations keep on going ahead in this particular aspect. Now, depending upon the routes by which an anesthetic agent is given, the general anesthetics agents are divided into drugs that are given by the inhalational route and drugs that are given by the intravenous route. Now let's talk about the various phases of general anesthesia. So now normally general anesthesia has been divided into three phases. The first one being induction, the second one being maintenance, and the third one being recovery. And all these phases are equally important because a miss in any of these phases could result in tragic consequences for a patient. Let's go further beyond what induction means. So, induction is from the time from onset of administration to the development of effective surgical anesthesia. Maintenance is you are providing a sustained anesthesia, and recovery is once you discontinue the anesthesia till the patient regains his consciousness and all his physiological reflexes are reverted back. So induction is onset, maintenance is continuing, and recovery is discontinuation and regaining the physiological reflexes. Now, once we talk about hypnosis, now this is a very thin line of demarcation between these. So this is like something like a step. The first step in this is amnesia, sorry, is awake. Awake is the next step is amnesia. This is followed by sedation. Sedation is followed by hypnosis. Hypnosis goes beyond to coma, and if things are not reverted back, it could lead to death of a patient. Now, what happens when we are talking about how traditional anesthesia was different from modern anesthesia? The one anesthesia that was given by in 1846 and on 16th October, which is celebrated at World Anesthesia Day. What was there was a particular compound, a single compound that was given. This is for monoanesthesia, specifically diethyl ether or ether was given. It reduced the pain sensitivity, caused the loss of reflex consciousness, caused muscle relaxation, and even caused paralysis of the vital centers. Now, all these were being produced by a single drug, and that too by varying the concentration of the drug. So, how is it different from modern anesthesia? In modern anesthesia, we have given each drug a single role. So what does that mean? That means lower amount of drug is now required and you could attain an anesthesia that is much better. So for unconsciousness, you could use halothane or propofol. For autonomic stabilization, you could use atropine. For muscle relaxation, you have those skeletal muscle relaxation. There is another term that is now that we use now, tragic for aging. You can go and now we have another term that has been very good. And the balance when you see them, not of God, we give giving the problem, we understand communication. Because it sets the stage for induction, and it is set up by induction, for the set up by maintenance, and another set of recovery. So for the pre-medication, we could have drugs that cause sedation and relief and alcohol for anesthesia, for auto stabilization. For induction, we could use Bhagavan, we utilize the patient, direct impact of the maintenance is one now, and more application of the protein. Recovery is being taken care by
the opioid analysis and the cholinergic or cholinergic inhibitors, drugs that are there that are deeply available and also yeah. Now, moving beyond this, we have the various stages of anesthesia. And these stages of anesthesia are typically diversity. We do not see stages now, but we have first of all, stages are very important and they are a benchmark of how people have. So we compare it with alcohol. So once a person starts consuming alcohol, initially he light food, followed by drunkenness and disorderliness, then he get drunk, and then it's being so similarly, we can start at the first stage. Movie here, there was uninhibited response. Followed by surgical anesthesia, that they reply. Now let's talk about further. So I repeatedly that this is the stage for the stage one and initial from action of anesthesia to loss of consciousness, and this loss of consciousness as loss of complex. The painful definition, but the patient is conscious, can hear and see the world around. So this is not an ideal stage for surgical anesthesia. Then there is another stage that is stage of treatment by treatment. Now this stage is characterized by unconnected circulation. The people are dilating that eyes is divergent, the patient is agitated, there is preliminary, there is irregular respiration, and potential death may be carried out. Now this is a dangerous stage for here and during this stage treatment is given, it will be vomiting, there is power, hypertension, and stage one, stage two are not ideal for the general anesthetics. What is the stage that is given for general anesthetics? For general anesthetics, we have stage two, that is stage of surgical anesthesia, where we have a temporal nail, regular, the target hypertension, cases that are optimistic, and any other preventive. Now, for the sake of gain money from return of regular respiration, condition of the human painting is surgical with also time here, the rapid eye stop, and there is parasympathetic rest by forming and this is followed by painting, which is from the onset of parasympathetic. It's now paid for from parasympathetic the patient acting that I am very precise for that. These are the agents not being surgical. If you go beyond this, there is another thing that is state parasympathetic medicine, a state where dilated or normal people, hyper there and so this is how each stages are anticipated. There classical now another term that is common is minimum alveolar. So this minimum alveolar concentration is the measure of yeah. Now how do we measure the so this is the end tidal concentration of gas that is about 50% GLH by a standard light and water. This means that if a drug or particular compound has a smaller concentration, it has high intensity, like the amount of drug that is required is lesser as compared to the drug which has potency. Another thing that is there is the uptake energy. So the depth of anesthesia obviously will depend upon the concentration and the partial pressure for anesthesia. Now, what is the role of the partial pressure? So let's talk about the role of this partial pressure. So this partial pressure depends upon one of factors that is the solubility of gas. So a drug which is overall that solubility that means lesser amount of molecules reaching the that would lead to a higher amount of thereby faster induction and solubility. Whereas a drug which is highly lipid soluble, it first gets dissolved in the blood and once it gets dissolved and rises, so it takes time to have slow induction and solubility. Another thing that is there is the blood gas partition coefficient, which is the index of solubility. The ratio of concentration of the gas which should be there. So once we are talking about the partial pressure, depending upon the potential, what you find is a low potential drug has high partial pressure and it will be at 2.5. Whereas halogen, which is highly soluble, has high potential, higher one, higher, it attains a lower partial pressure, highly soluble, and it has a significantly higher magnitude. We should position how this particular one acts. Now, what are the various factors that can affect the partial pressure? The various factors that can affect the partial pressure are the partial pressure of anesthetic expiry, the concentration, washing, inflammation, and elimination obviously. Now, once uptake is done, now discontinue it, so elimination starts. So the elimination of yield anesthetic is done. And if the similar factors as well as pressure are involved, elimination. Second one, solubility and pressure. So nitric oxide in vessel liquid soluble has that vessel has a higher partial pressure and it exits faster than heavy. And drugs that are highly liquid soluble longer duration of time. So this is what we are writing to understand that is the second gas effect hypoxia. Now this second gas effect seen with those drugs that have or relatively lower lipid solubility or less solubility blood and this specific resource nitrous oxide. So this drug, few molecules of this drug can't enter the blood. There is sharp rise in the partial pressure. This nitrous oxide is lesser soluble. So any limited amount of drug or higher rise and this particular gas and other gas associated with it would be subject to the same as nitrous oxide. So this is second gas. The opposite PH3.1 is properties. So any drug that is purely soluble, the nitrous oxide, it will have the same phenomenon. Few molecules going out of the alveoli, it will be eliminated at a greater rate, thereby adding as the one meter of here. So this gas is completely back in here and that for the at the time of inspired hypoxia. So this particular hypoxia is high and its magnitude is insignificant as a so these are few of the preliminary plans that the data that I've diagnosed. And I'll finish my session out here. So if there are any questions on this session, to get back to me and I'll be happy to get back to you. Thank you so much for the question, and have a thank you so much.